Okay, students. So in the previous classes, I discussed to you about epidemiology, the general overview of breast cancer, the diagnosis. In the diagnosis, I told you TNM staging is very much important, where you will get to know which stage the cancer is in, and that staging I was telling is very much important for you to take a call in treatment part. Okay, so today our discussion will be mainly focused on management, overall management of breast cancer. So these things, prognostic factor, and all we discussed in the last class. So as you know, the format, how the format goes in pharmacotherapeutics when we start discussing the treatment. First thing is what? When you start writing the treatment of any disease in pharmacotherapy, what you include first point?
Outcomes, desired outcomes,
Goal
goals
of
of
treatment.
treatment.
Yeah, goals of treatment. Okay, goals of treatment. So this is what you should know for the goal of breast cancer treatment. Okay, when you start treating the breast cancer, what should be your goal? So your goal should be, if the your goal will depend on the stage. Okay, again, if you remember yesterday I was telling stage is very important. If you know the stage and the type of disease, based on that the therapy is going to be. So now if the breast cancer is in early stage, that is early breast cancer or locally advanced breast cancer, then the goal should be to cure it. Okay, and I hope you know what is early breast cancer and what is locally advanced breast cancer. You know, right? Yesterday itself we discussed, isn't it?
Yes, sir.
Yes, sir.
Okay, so but
Yes.
if the type of the cancer is metastatic breast cancer, okay, in short also known as MBC. Okay, so now onwards, whenever I say MBC, you try to understand that I'm referring to metastatic breast cancer. For this breast cancer, we cannot aim to cure. Okay, we cannot have a fix a goal to cure it, but the goal would be, the realistic goal would be to improve the symptoms, to make the patient symptomatically more better, to increase the quality of life and prolong the lifespan of the patient. These three goals should be for the metastatic breast cancer. Okay, you ensure that even in your exam you write the same goal. No, you don't make something by your own and then just fill the paper. Okay, like decreasing the side effect, blah blah, whatever you people write usually. So what I mean is, you try to stick with the appropriate exact goal for each disease. It's not only about disease you are seeing here, it's about even the stage, in which stage what goal you are fixing. You cannot fix your goal to cure metastatic breast cancer. Okay, so you should know what you are telling. That's what I mean. So now coming to the treatment part, the treatment of the breast cancer is rapidly evolving. That means, yesterday we saw many of the controversial things going in around. Some studies showed one thing, another studies showed another thing, and the conclusion was not very clear. So similarly, the same goes even for the treatment part. There is no, like, we see some of the treatment which say this is beneficial over the combination therapy is beneficial over monotherapy, or this drug is beneficial over um, uh, that drug. But overall, the things that you need to see is, you should get updated with the recent literature. Okay, recent literature, what it is being shown or proven in the recent trial. Okay, recent phase 3 trial, what is being done currently, and what is the update. So that is why that it is said that treatment of breast cancer is rapidly evolving. Okay, and you all know these drugs can cause very so many of side effects. This can be very cytotoxic, and this cytotoxic again differs from what drug you are using. Okay, what way, in what administration method way you are using, whether you are using single therapy or combination therapy. So the toxicity will depend on all these factors. Okay, we'll see some of the when we discuss some treatment, we'll see the toxicity also of that particular treatment. We'll see that. So early breast cancer, we'll see the treatment of first early breast cancer. So I hope you know what is early breast cancer.
Yes, sir.
What is that?
Yes.
Sir,
Stage 1 and
stage 0, 1, and 2.
We don't say zero. We say
stage 1 and 2.
had I told stage zero? Stage
Not
1
one.
and 2. Okay, stage 1 and 2 is called early breast cancer. Okay, so we'll see what are the treatment modality of early breast cancer. One modality. Okay, the first modality is local or local to regional therapy. That means we are not giving a systemic drug. Okay, that means we are treating the breast cancer locally. Okay, we'll see what are those methods. For example, we do surgery. For example, we give radiation therapy to that region. Okay, so those are the local regional therapy. So we'll discuss this modality in this heading. So and this uh, actually for in situ cancer. In situ means as Ravi was telling right now, in situ means stage 0. Ravi.
Yes, sir. It's stage 0. In
Yeah.
situ is stage
Hmm.
0.
That means this cancer have not spread to the like have and there is no much involvement of lymph node and the chest wall and all this. Like it is very localized. Okay, that is why for in situ cancer, if you see the cure rate is approximately like most of the patient who have in situ cancer get cured by this surgery alone. Okay, and those who are like in stage 2, approximately one half, that means approximately 50% of the cure rate. Only this surgery can be enough to do to achieve that. Okay, so with surgery in situ cancer can be cured almost like 100%, not 100% exactly, but almost um, completely. But in case of like stage 2 cancer, it can still the surgery can be still a cure. um, the surgery can still cure by the rate of 50%. We have something called breast conserving therapy. Okay, so this has come recently actually. Previously, there was something called modified. So first of all, there was radical mastectomy. Okay, so mastectomy is complete removal of breast. So this radical mastectomy, they came because initially it was not thought that, if you see the history, it was not thought that breast cancer is a systemic disease. Systemic disease means it can like metastasize and go affect many other organs. Initially, it was felt like this is a local local disease, and they were treating um, on that basis, on that principle. So initially it was radical mastectomy, but because of many concern, for example, one of the major concern was cosmetic issue. So because of many concern, they modified this radical mastectomy and further modified is breast conserving therapy. So now they do lumpectomy, like that means they remove the particular tumor from the breast or the some tissue around that tumor, but they try to conserve the breast. Like they don't go for total mastectomy, complete removal of the breast. So that is called breast conserving therapy. Okay, so if the disease in stage 1 and stage 2, breast conserving therapy or BCT is appropriate. And they come because they switch to BCT over this radical mastectomy because they found that the overall survival rate was very much equivalent, and this BCT is cosmetically superior than mastectomy. Okay, so BCT consists of lumpectomy, that's what I told, excision of primary tumor and some adjacent breast tissue. After that, they go for radiation therapy. To just to prevent again recurrence. Okay, so they do the BCT, that is lumpectomy, and then they go for radiation therapy. Coming to radiation therapy is administered entire breast over 4 to 6 weeks. That means 1 to 1.5 months. This helps to eradicate the residual disease, whatever residual tumor is there after BCT. But some of the side effects of this radiation therapy are like reddening, erythema of the breast tissue, and sometimes the shrinkage of the breast total mass. Because they estimate before putting the patient on this radiation and on this breast cancer therapy, breast cancer treatment, what they will do is breast conserving therapy. What they will do is they will estimate, okay, this is the estimated decrease in breast mass or breast size. Okay, so but this estimate doesn't work sometimes very accurately because of this radiation therapy. Sometimes this radiation therapy will cause more shrinkage of total breast mass. Okay, These are minor complications associated with the radiation therapy. So this is what I was talking. Simple or total mastectomy involves a removal of the entire breast. Okay, that is total mastectomy or simple mastectomy, without dissection of underlying muscles or axillary nodes. Okay, so they don't dissect, they don't separate, it's complete removal. So this procedure is used for carcinoma in situ, where carcinoma in situ we told we can do BCT, you can go for BCT, you can go for surgery, but if the condition is like if there is involvement of muscles, underlying muscles and axillary nodes, then they can go for simple or total mastectomy. Okay, if there is like more involvement of axillary node. Axillary lymph nodes should be sampled. Again, we discussed yesterday that based on T and M, we can do the staging and we can have prognostic information. What should be the what would be the prognosis of that stage? So this axillary lymph node can be like taken with the biopsy, through biopsy, and they can do the prognosis. There is something called sentinel lymph node biopsy. Okay, when we discussed yesterday about biopsy, this is the one special type of biopsy. First of all, you should understand, okay, what is sentinel lymph node? Okay, anybody, what is sentinel lymph node? This is the same meaning as in English. If you know the English meaning of sentinel, you can understand the sentinel lymph node as well. Anybody? Okay, sentinel means the starting point. Okay, so sentinel lymph node means the beginner lymph node where the tumor started initially. From that lymph node, the drainage will happen to other lymph node, and then subsequent metastasis will happen. So here, what is the hypothesis is that if you take a sample from sentinel lymph node, then you can better predict you can have prognostic factor about the spread and the stage of the disease. So that's what lymphatic mapping with sentinel lymph node biopsy is, something new and alternative to axillary dissection. So now, what we discussed now, Dibya, what topic we discussed now? What topic we completed now?
There are surgery there are for treatment for breast cancer.
Treatment of breast cancer, okay, but what topic, under what heading we are discussing? Local regional therapy. Okay, local regional, these are local. Yes, surgery, you told correct. So local regional therapy. Okay, so this was one thing, but now moving towards systemic adjuvant therapy. As I told, later on they proved that this breast cancer is not confined to local this thing. This gets spread to many other organs. So then they came with the concept that we have to treat systematically also. So I hope you know what is adjuvant therapy. Adjuvant
Yes, sir.
therapy, if you remember, we had some terminology.
Additional.
Yes, sir.
That adjuvant meaning you read in your this Sutix and all. Here I'm asking you in terms of chemotherapy. We had discussed what is adjuvant, what is neoadjuvant, all these things. So adjuvant therapy here is a systemic therapy you give after the local therapy, that may be surgery or radiation therapy. So that is adjuvant therapy here. Immediately you did surgery or radiation, then you go for the systemic adjuvant therapy. Okay. So this is again to ensure that there is no likelihood of reoccurrence. Again, the goal of such therapy is to cure. So this adjuvant therapy you can do by giving chemotherapy, okay, and or by giving hormonal therapy. We'll discuss both here, okay, chemotherapy and hormonal therapy. So we'll see what are these chemotherapy that you can give as systemic adjuvant therapy for the breast cancer, for the early breast cancer. We are discussing right now for the early breast cancer. Okay, remember that early breast cancer we discussed local regional therapy, and then now we are going to systemic adjuvant therapy. So in systemic adjuvant therapy, we are going to discuss chemotherapy and hormonal therapy. So these both can actually increase the overall survival, in short abbreviated as OS. So that is why we go for this chemotherapy and hormonal therapy. The National Comprehensive Cancer Network practice guideline reflect the trend towards the use of chemotherapy in all women, regardless of menopausal status. So this is the guideline which says that regardless of menopausal status and additional of hormonal therapy in all women, like we should go for this chemotherapy. That's what it is being advised by the guideline. And hormonal therapy, when it comes to hormonal therapy, we say that if there is receptor for that drug, then only that drug will act, right? Similarly, we have, if the female patient have HER2 positive receptor, okay, what is HER2, Ravi? Can you tell?
HER2, human epidermal growth factor.
Correct. Human epidermal growth factor, like we in genetic. Do you remember in genetic factor we discussed some of the genes? One of this was HER2,
yes,
another was BRCA1 and BRCA2. So these, if the patient is having this HER2 positive receptor, then only this hormonal therapy is going to work. Otherwise, they won't find the receptor to act, and the patient will not get any effect. Okay. So coming to adjuvant therapy, adjuvant chemotherapy, I told you we'll discuss both here. Do you remember? Adjuvant chemotherapy and what else? Hormonal therapy. So this adjuvant chemotherapy and adjuvant hormonal therapy we are discussing under what heading? Systemic adjuvant therapy. Okay. Before that, we discussed local regional therapy for early breast cancer. Okay. We are still discussing the treatment of early breast cancer. Clear? So adjuvant chemotherapy, this may be again combination or sometimes even single regimen, but combination regimen have been shown to be more effective than single agent chemotherapy. We'll see in this table. We have a nice table here. So we'll see here. This table gives the overview and summary of all the regimen. Okay, we'll come back to this table soon. But first of all, let us see some of the things about chemotherapy. So you remember we have a class called anthracycline, okay, which contains a drug like doxorubicin, epirubicin. So this anthracycline containing regimen, that means whatever regimen, we'll discuss what is regimen. Regimen is like combination of these 2-3 anti-cancer drugs. So whatever this combination or regimen consists of this anthracycline, this have reduced the rate of recurrence and improved the overall survival over 5 to 10 years, okay, when we have used this anthracycline containing regimen. But the same was not found with cyclophosphamide, methotrexate, and fluorouracil. So right now we are basically comparing anthracycline based regimen with cyclophosphamide, methotrexate, and fluorouracil. Okay, so we found that the anthracycline based regimen improved the overall survival from like 5 to reduce the reoccurrence and improve the overall survival like 5 to 10 years. Okay, so this regimen have worked for both node negative and node positive patients. Okay, I hope you remember, or you know what is node negative and node positive. That's why I spent some more time yesterday on staging. You know, T and M. If N is 0, there is no nodal involvement. If N is more than 0, there is nodal involvement. Okay, so if there is a nodal involvement, or even if the nodal involvement is not there, this anthracycline based regimen has shown to be working very effectively. So the addition of this taxane class of drug. So when I say taxane, I'm talking about docetaxel and paclitaxel kind of drug. So these are a newer class of agents. So the addition of these to the anthracycline based regimen have even shown to improve the disease-free survival and overall survival in node positive breast cancer very significantly. So if we add taxane in those regimens, maybe docetaxel or paclitaxel. So this, I told you this chemotherapy we are starting when? Before the surgery, isn't it?
After the surgery.
After the
no,
surgery.
sir, after the surgery.
After the surgery. Before the surgery, if we start, we call it as neoadjuvant. Okay.
Neoadjuvant.
Neoadjuvant, not the adjuvant. Okay. So this is after once you did the surgery, and once you either you had radiation therapy. After that, we start the chemotherapy. So this is like after 3 weeks of surgical removal of primary tumor. Okay, after 21 days, this has to be started, and the optimal duration may go up to somewhere 12 weeks to 24 weeks. Okay, the duration of the chemotherapy. There is something called dose intensity. Okay, you have to know the meaning of dose intensity. So the definition is very pretty clear. In per unit time, what is the amount of drug you give? Okay, per unit time, what's the amount of drug you are giving? For example, in less time, if you are giving more drug, that is less dense, isn't it?
More denser.
More dense. If in less time, if you are giving more dose, that means more dose density is more. Okay, that means what I want to make you understand is by altering these two factors. One is time, another is amount of dose of the drug. You can alter the dose intensity. Okay, for if you increase the time and decrease the dose, then the dose intensity gonna decrease. Okay, so you can play with these two parameters to adjust the dose intensity. So there's something called dose density. Okay, so again, this is very easy. Don't go don't complex by thinking much. Dose density is simply a way of achieving the dose intensity. So dose intensity, I told you what is like in less time, in particular time, how much dose you are giving, that is the dose intensity. So to increase the dose intensity, you can go for the dose density. Okay, so that is this dose density. How it works is you decrease the time between two cycles. Okay, you decrease the time between two cycles. That's what I told. No, in less time, how much drug you are giving. So that's the dose intensity. So dose density is a technique to increase the dose intensity by decreasing the time between two cycles. So you are decreasing the time, you are increasing the dose density. So dose intensity, that is by dose density. Okay, so don't get confused between these two terminology. Don't dose intensity and dose density. So dense dose regimen may be considered as option for adjuvant therapy for those type of cancer who have like positive nodal effect. So if there is positive node, you can go for dose dense regimen. We'll see some of the regimen when we discuss what are those. So talking about standard regimen, if you go with the standard regimen and increase the dose, you may not get more effect. Okay, but you may get some of the toxicity. The patient may get some of the toxicity. So standard regimen should be like kind of used in a standard way. We cannot dose dense by your own way. There is a dense dose regimen itself for the if you want to use the dense dose regimen, or if you want to switch to the regimen. The standard regimen should be used in a standard way. So there are some short-term toxicity of this adjuvant chemotherapy, can you tell some toxicity of this chemotherapy?